Good morning, everyone. It's my greatest pleasure to welcome you all on that sunny morning and to introduce my colleague Maria Mileta Consolata. She's a young, inspiring scientist who did her PhD with Primus Mullis in Bern, 2014. Afterwards, she worked shortly with Anna Lauber before moving to Yale, to the lab of Tamas Horvath, where she stayed until 2020, and afterwards she came back to Zurich, where she's now heading the lab of, I hope that I can remember correctly, nutrition, growth and neurodevelopment of the newborn, of the neonatology. And she is specifically interested in how our early life is impacting hypothalamic neuronal function to lead to bulimia and anorexia. And I'm very excited to hear her talk. So, Maria, stage is yours.
Good morning, and thank you for the invitation. I'm very happy to be here today. I'm going to talk about my current project, which is about the hypothalamic underpinnings of anorexia nervosa. Okay. As you may know, anorexia nervosa is a psychiatric disorder mainly characterized by self-induced starvation, severe body weight loss, hyperactivity, and hypothermia, and self-distort images. The repercussions are both physical and psychological. Anorexia should be considered as a multi-system disease because it affects a lot of, I'm sorry, I need to move there because I cannot see my slides. And anorexia is mainly affecting, is a multi-system disorder, and the first, it's mainly affect the bones, but it's considered by reduction of bone density, abnormally slow heart rate, and low blood pressure. Mainly loss of menstrual cycle for women, and muscle loss and weakness. Severe dehydration, which can result in kidney failure, dry hair and skin, hair loss, which is very common. What we know about the epidemiology is that it's mainly diagnosed in adolescent women. In fact, it's the third most common chronic disease among adolescents. 95% of anorexic patients are women between age 12 to 26 years old. And the ratio of girls to boys diagnosed with anorexia is 9:1. That means every 9 women, a boy is diagnosed with anorexia. I should mention that the reason why there are so many little boys diagnosed with anorexia is because mainly they are not reported for this disease. But now things are changing, and the numbers are quite increasing. There is no difference of the eating disorder between white women and minorities. So what we know about the pathophysiology of anorexia is very little, almost nothing. We know that it's a complex disorder, which has a complex etiology, which mainly involve psychological factors, sociocultural factors, and of course, the genetics. Because the etiology is so complex, it's also very difficult to model with an animal model, and that's why so far, although anorexia is the highest, has the highest mortality rate among psychiatric illnesses, between 5 to 20% of affected individuals will die, there is currently no cure for anorexia. If you make a confrontation with schizophrenia or other psychiatric disorders. Mainly the treatment involves 2 phases, which is first the weight restoration, which is the first line for inpatient and outpatients, and the second is psychological counseling and antidepressant. And there are no current medication for what is the impact on the main symptoms, which is fasting. I should also mention that because the neurobiology is poor known, the relapse rate is also very high, and the percentage of people presenting chronic disease is also high, around 20 to 25%. So what we did was to interrogate whether the hypothalamus, which is a brain region which counts only 0.3% of the total brain, might be involved in the etiology and pathophysiology of anorexia. Of the whole hypothalamus, we chose a specific nucleus. The hypothalamus is a region which is highly conserved between mammals, and it's formed by several nuclei. That means that there is an incredible cell diversity. But we chose to focus on a specific nucleus, which is called arcuate nucleus, and out of this, on a specific population of neuron, specifically two populations, agouti-related protein and POMC neuron. Here in this presentation, I will mainly discuss about agouti-related protein. What is important about this region is that they can sense peripheral hormonal signaling. That means they can respond to leptin and to ghrelin. Usually, AGRP neurons are active during fasting, and they can respond with active feeding. Ablation of AGRP neuron in neonatal age, it's mainly can cause death. Now, when I was in my previous lab at Yale, they have found that these neurons are not only involved in feeding, but they control compulsive behavior. So they are associated to circular neurons that control anxious disorder and compulsive behavior. So what happens when the AGRP neuron get active, but in absence of food, the mouse develop compulsive behavior. And that's very important because it's not so usual for a family of neuron controlling feeding being relating to someone which is not strictly relating to the feeding itself. So the aim of this study was to investigate alter agouti-related protein circuit activity, early postnatally and postpubertal, on phenotype development in a mouse model of anorexia nervosa. Basically, we investigated what will happen to the progression and maintenance of this disorder if these neurons are there or not. To this aim, we use a well-established biobehavioral phenomenon, which is called activity-based anorexia model. This model is known since 1967 and is based on the principle that in absence of food and in presence of a running wheel, the mouse will choose to run instead to eat, even in presence of food. This will drive the mouse to death. So it models very anorexia in terms of compulsive behavior, severe body weight loss, and hypoleptinemia. As I said, this model is very well established, and very shortly, the mouse is put in a running wheel, with a running wheel and with access to food for 4 days, and this phase is called acclimation. Following this phase, the food is removed, and the mouse will have access to food only for 2 hours per day at the beginning of the dark phase, for 72 hours. The time is so restricted because we mainly use adolescent women, female and male mice. After these 3 days, the mice are back to the running wheel is removed, and as well as food, and the mouse can recover for 3-4 days. Actually, we made them recover for almost 1 week before undergoing 2 additional behavioral tests. As a sedentary control, we use mice that have access, that did not have access to the running wheel, but that were food restricted as well. And this control are called sedentary mice, sedentary control. So now, there were some hints that this neuron might be involved in anorexia. When we look at the data, AGRP neuron concentration is increased in the blood of anorexia people. And the level of AGRP protein are increased and related to cognitive rigidity in those patients. There are also data showing that because AGRP neurons are so crucial during prolonged period of fasting and get actively activated, they can promote the progression and the maintenance of this disorder. So the first question that we ask is, okay, what is the involvement of this neuron in the experimental setting that we are proposing? Are they involved or not? I think You might be familiar with fiber photometry. Basically, we inject in newborn mice a virus containing a calcium dye, and the idea was to measure calcium recording in order to measure the activity of this neuron. At day 40, we fast the mice and we put them on a running wheel to measure or not if IGRP neuron get active or not following the running period. What we found is that I should mention that the mouse was not forced to run and there was no punishment. The activity is continuously spontaneous. So what we found is that at the beginning of the running boot, we could not see any variation in the activity of the AGRP neuron. And this is consistent with previous results. But what we found is that the end of the running boot caused a decrease in the activity of the AGRP neuron. It means when the mouse jumped out of the running wheel, the AGRP neuron also shut off. What we also saw is to have some food clued presentation. That means that at the end of the run, food is shown to the mouse. It was previously shown that any time a mouse sees some food, the AGRP neuron, also the activity shut down. But what we see here is that the end of the running was 50% greater than when food was presented. And so we conclude that AGRP neurons are involved in the behavioral responses in an activity-based anorexia model. The second question was, okay, but what will happen if we ablate completely the neuron in a mouse? So what we did is to use a mouse model that expressed the receptor for the diphtheria toxin only in the AGRP. This model allowed the selective ablation of neuron through injection during the neonatal life of diphtheria toxin. And you can see that the level of ablation was consistent with the genotype of the mouse. After this, the mice underwent to the ABBA paradigm. I should say that there are control, but please look at the running AGRP ablated mice. So what we see is that during ablation, there was basically no difference in body weight, calorie intake during 24 hours among group, not even between the running wheel. But when food restrictions start, we saw that the weight immediately decreased in both sedentary control and running control. And the weight loss was severe in the mice missing AGRP neuron, was almost 26%. In parallel, we see that the mice start to eat less and less, and there was a decrease in the running capacity. You can see that the mouse stopped. And by the end of the food restriction, 100% of the mice died. So no one was able to face the challenge of the ABBA paradigm. And all body necropsy here show severe dehydration and almost depletion of the fat tissue. Only in the running AGRP mice, depleting mice, but not in the sedentary control. So, okay, well, it seems that this neuron seems to be crucial for the mice to be able to run while they are food restricted. So we say, but what will happen if we overactivate this neuron? And to this aim, we use a completely different mouse model. In this case, we activate the AGRP neuron, express a calcium receptor. This calcium receptor can temporarily be activated through caspicin. We did the activation far from food. And these mice undergo also to the ABBA paradigm. What you can see here, it's almost no changes during the acclimation in body weight, food intake, and caloric intake, and running ability. But incredibly, although the food intake stay the same during the paradigm, the AGRP, the mice with activated AGRP were able to run 2 days longer compared to the control, before showing sign of physical exhaustion. Additionally, you can see here that without there was any effect on the lethality. That means all the mice survived through the paradigm. And I will try now to show you how crazy was the run. So you can see here how the mice get skinnier and skinnier, but still go crazy, desperate is the running, although the caloric intake was minimal. So we were thinking, okay, so maybe possibly this effect is because the AGRP mice don't eat enough. So we decided to provide a minimal caloric intake to the mice with activated AGRP and to see if the lethality would be affected. And what we see here is that mice with activated AGRP run and survive with a minimal caloric intake, the same caloric intake that make the mice missing AGRP neuron dying. So here you can see that there was no lethality, and they run, so they survive, and the body weight, the loss of the body weight was the same. When we run, actually the body needs to counteract this effect, mobilizing free fatty acid. So in this case, we went to analyze free fatty acid, ketone bodies, and glucose in both mice line. What we see here is that the AGRP DTR mice are not able, the free fatty acid concentration decreased over the time. There was in parallel an early increase in ketone bodies and a sharp decrease in glucose, which results in severe hypoglycemia in the 72 hours. All this caused the highest mortality. So it seems that mice missing AGRP neuron cannot cope with the metabolic challenge given by the ABA. On the opposite, the AGRP TRPV1 mice show high circulating free fatty acids, and therefore stable ketone bodies during the food restriction and stable glucose. So what this doesn't mean means that there is a metabolic regulation which is driven by the AGRP neuron. They can control nutrients utilization in order to promote or not the survival during the food restricted running. So next we saw that because during the fasting we need fatty acid to replace the diet with to increase the free fatty acid, to provide high-fat diet. So these mice, before going to the ABA and during the ABA, were providing high-fat diet. What we see here is that, of course, there is immediately a high caloric intake, because to equal amount eaten, the high-fat diet provide more caloric intake. But what we saw in that the mice lacking AGRP, they survive, and they were able to run and finish the food restriction period. So we were able to rescue the survival, just providing high-fat diet during the ABA paradigm. And in AGRP TRPV1 mice, what we saw is that the mice, when they were able to run longer, they were able to run for 11 days without any kind of lethality. And I have to say, at this time, we decided to stop, but they could run even longer. So we see that activation or inactivation of AGRP neuron can modulate the activity, can modulate the nutrients utilization. But what about the behavior? Anorexia nervosa is linked to several behavioral abnormality, especially the patients show increased anxiety and compulsive exercise. The idea is that compulsive exercise in anorexic patients should help them to with the fasting, because somehow it calms them down. So it's a bidirectional. So what we saw here, we ran some behavioral tests on mice, and we see elevated zero for the anxious. We see that the running AGRP-DTR, the running AGRP-TRPV1, they were less anxious, but they were more compulsive compulsion is measured by this behavioral test, which is called Marlborough-Berry, and it measures the overall activity of the mouse in 10 minutes time. So what we saw is that when we activate the HRP neuron, the mouse become more compulsive, more prone to make compulsive exercise, but less anxious. At the same time, when we provide high-fat diet, which is well known to be a physiological inactivator of the HRP neuron, the mice become, there was no impact on the anxious, but they become less compulsive. So it seems that this neuron, in parallel to the nutrients utilization, were able to control the behavioral aspect of anorexia. So the main conclusion of this study is that HRP neuron control the survival of food-restricted animal with compulsive exercise, but also determine a long-term behavioral impact on compulsive exercise during fasting. This study is the first time where it showed that a single family neuron can control behavior and nutrients utilization in a mouse model of anorexia nervosa. The whole message is that when the neuronal signal of hunger is not fulfilled by appropriate food intake, HRP neuron can orchestrate a complex response, which promotes both no-feeding behaviors and peripheral metabolic changes, which are necessary for behavioral integrity and survival. But the main conclusion is also that a fundamental metabolic dysregulation may contribute to the exceptional difficulty to treat this individual, even after therapeutic renourishment. Thank you very much for being here, and I'm happy to receive your question.
Thanks so much, Maria, for this exciting talk and the exciting data, and that you shared it with us. I just want to first ask if there are any questions, online questions from the chat. Not at the moment, so then from the plenary. Are there any questions?
Thank you for your very interesting presentation. If we look at humans after mice, could anorexia athletica be a good model for you? You have a compulsion, like you described here.
Absolutely.
You can feed them. Well, we don't need to feed them down because they're anorectic. So what kind of study would you do in humans, which would be a follow-up of your animal study?
Thank you. That's a great question. And it means that also the clinical base start to be aware of the current paradigm shift that is underway to look at this disorder not only as a psychiatric disorder, but as a psychiatric disorder with strong metabolic components. So something that it's under the way, it's currently undergoing in US, is to provide the ketone body diet in anorexic patients. This would help them with the phobia they have with the feeding, and we give small portion so they don't have to have the phobia of feeding, and will help stabilize them because it stabilizes the tendency to run. There are some few data which are promising.
I think it's really exciting because it's actually the first time that there is like hope for these patients.
Yes.
and really a physiological attempt to treat not only body weight, that is usually failing over time, right?
Exactly.
But to really address the compulsive exercise behavior that these patients show and that they suffer from.
Absolutely.
Are there any other questions from the audience at the moment?
Could you speculate on the effects that could make for treatment of obese people. So perhaps so first step will be to develop pharmaceutical agents for anorexia or against anorexia. But what's the speculation with respect to obesity? And perhaps you prepare already experiments with obese mice in this aspect.
In this aspect, yes. There is a current ongoing speculation that this feeding circuit, which is regulated by the AGRP and the POMC, could be altered in anorexia and in bulimia. Maybe this is a pure speculation. In patients which are obese, the circuit works towards the POMC or towards a lower activation of AGRP. And that's why now we need research with high translational impact, which might use mice but also human to test this hypothesis. And patients-derived cell model actually would solve the problem.
Maybe allow me one more question. So what I would be very interested to know is, how do these fatty acids or ketone bodies actually resolve the problem? So which regions in the brain are activated? Did you investigate it? Did you have a look at that?
Let's say they have a multiple impact, but as I said, the main circuit is AGRP-POMC. It seems to shut down the activity of the AGRP, calm down, so the activation of this neuron is less exacerbated, and at the same time, it provides stability over the glucose level. I don't know if I replied to your question.
Could the same be, I don't know if there is any, but could the same be achieved by an AGRP inhibitor?
Yes, but there is no one in the market at the moment.
Yeah, I mean, best is if we have a natural inhibitor, right?
Yes.
Like ketone bodies or fatty acids.
But of course, all the hormonal balances that can achieve to have an action of this circuit can be of importance. Leptin, ghrelin, especially insulin.
Thanks a lot. Are there more questions from the audience? If not, then we have here an online question that is: high serum free fatty acids usually are a result of elevated sympathetic tone. Do you know a mouse model where sympathetic activity neural output has been measured?
This is a proper question. That's absolutely true. And in a previous study that was done in my lab, they do measure the sympathetic activity. And actually, the inactivation of AGRP neuron increase the sympathetic activity tone. So this is a very proper question.
Okay, thanks a lot. Any other questions from the audience? If not, then I have maybe a last one. So we know that one very recent molecule or hormone also induces anorexia, so massive reduction of body weight, and that is GDF15 that is acting in the hindbrain. So that could also, and I mean GDF15 receptor or GFRAL antagonists are being developed to actually counteract anorexia or cachexia. So how do you see GDF15 inhibitors or neutralizers in the field of anorexia?
Well, something definitely to be tested. Something that needs definitely to be tested because it's a proper market to look at that. But there are no data, so it's an open field full of exploration. As I say, traditionally, anorexia is seen as a psychiatric disorder, but now we know that the metabolic components are not only the consequence of the anorexia, but they can take part to causing anorexia too.
Yeah, I have to say from my own experience, I mean, I'm usually treating obese patients, and that is already very challenging, but it's not comparable to treat anorectic patients. I think that's really the hardest thing in clinical daily life, and can be very frustrating.
Yes.
And I think what we also have to all keep in mind, maybe you ask yourself like, am I in the wrong session or what? Today is obesity, but what we see, and I think you fully agree with me, is that a lot of people that we see with heavy obesity, they faced anorexia earlier in their life. So I think it's the same disease with two pictures that can be seen. So can you integrate that clinical picture that we have, so basically two opposing diseases within the same person, like with your preclinical results? So how would that go together?
Obesity and anorexia, they are at the extreme of a spectrum, and we know that both of them are driven by genetic components. It might seem strange to think that who is prone to bulimia cannot develop anorexia, but what we see actually, it's most of the time eating disorder develop in who face a problem to cope with complex eating behaviors. There is an expert after me that can reply to this. So I think the preclinical studies at the moment focus on one or in the other one. But the human models can definitely reply to such a question.
So when we take into account your findings, could it be like that when a previously anorectic person is then eating a lot of high-fat diet, so a lot of fatty acids, that is then switching like AGRP neuron activity then to the opposite, and then it just fades?
It's a very interesting hypothesis, because we do believe that this circuit can be modulated. And that's why, for example, the first modulation, it's the body weight, right? This circuit responds to body weight and to leptin signal. So anytime the first things when you restore the body weight is to restore the normal leptin level. And because the AGRP neurons are so sensitive to leptin, the leptin is able to shut down this. For example, I know that many of you knew a study that was published in the England Journal of Medicine, when they were restoring fertility in anorexic patients, just providing leptin. So I do believe that modulating this circuit revealed to be crucial in both directions, anorexia and bulimia.
Thanks a lot, Maria.
Thank you so much for having me here.
I just wanted to say that we are trying to give leptin to anorexic patients with compulsive exercise. And
fatty acid, ketone bodies, we can try.
With the leptin with good results, but not yet published.
Yes, I do believe that, as I say, this circuit can be modulated.
So thanks so much for this lively discussion, and I hand over to my colleague Dagmar.
Really?
Thank you. Good morning, everybody. I would like to welcome you from the part of the Swiss Association of Childhood Obesity. And I thank you, the organizers, to be present here as a representation of pediatric obesity. And on the other hand, I thank you for your interest in appetite regulation and obesity. First, I would like you to wear the mask herein. We are, despite the certificate, you have to wear the mask herein because it's a hospital, sorry. The speakers can take it off. In the ACI, the Swiss Association of Pediatric Obesity, we ask ourselves how often occur the eating disorders in childhood obesity. And fortunately, that is not more frequent than in the normal population. But we ask ourselves what may be the consequences of a therapy of obesity. And we know that may be, as we discussed it before, they may result in anorexia. But what forms of anorexia are existing now? And that is the chapter for the next speaker. That is Patrick Pasi. He is a psychiatrist, and he is the head of the Center for Eating Disorders at the University Hospital in Zurich. And he is also the co-president of the AKI. And he is, in addition, he is also a board member of the Swiss Patient Organization for Obesity of the SAPS. So, Patrick, welcome, and it's your turn. The name of the presentation is Diagnosis and Multidisciplinary Treatments of Atypical Eating Disorders as Muscle Dysmorphia and Others. Thank you.
Thank you very much, Dagmar, for the nice presentation. I will talk about atypical eating disorders. I hope my English is good enough. I'm Swiss Italian. I never did it before, but I will try. Because I am co-president of the AKI, I will begin with adolescents, with a survey of the city of Zurich, a scholar survey about adolescent body awareness. And we saw that 50% of girls want to be slimmer, and 75% of boys want to be more muscular, and 1/3 of adolescents feel somewhat burdened by their body shape. And why are young people so vulnerable to body dissatisfaction? Maybe because of the obesity stigma. We will have the next talk about this. We know that it's very difficult for obese young people in the school to be obese. Many people think that obesity is associated with negative characteristics, stupid, lazy, slow. No one wants to play with these young people, and overweight people suffer from greatly reduced self-esteem. Time trends are the driving for thinness increases in younger generation. There is a higher incidence of anorexia in girls under 50 years of age. They become younger and younger over time, and there is an increase in atypical eating disorders in adulthood. And what are atypical eating disorders? That they are disorders that don't meet the classic criteria for a specific eating disorder like anorexia, bulimia, or binge eating. They don't have all the features of one clinical picture, or they are very, very recent and have not yet found their way in the classification systems. We know, this is an old study from Fairburn, that eating disorder types can change across the lifespan. The patient can begin with an anorexia, then move on to a bulimia or a binge eating disorder, then recover, and then begin with anorexia again. There is a shift, the possibility to shift to another eating disorder type, so that we have a transdiagnostic cognitive behavioral model of eating disorder, including binge eating, starvation, low weight, bulimia, and saying that the core symptoms of the eating disorder, like drive for thinness and body dissatisfaction, are modulated by personality traits like perfectionism and low self-esteem, leading to neurobiological changes after adolescence and pathological eating, and maybe chronicity when not treated. We have heard before, anorexia is not only a psychiatric illness, it's a metabolic illness too, with changes in hormonal axis, changes in appetite regulating hormones, and pro-inflammatory cytokines. with the somatic complication that we have heard from my former speaker. There is also, we have heard about that, there is a change in neurotransmitter in the satiation and in the appetite centers of the hypothalamus. All these neurotransmitters are involved, leptin and ghrelin being the important ones. There is also changes in the microbiome in the gut-brain axis in anorexia. So a change of microbes can cause an inflammation in the intestine, and then this altered information go to the satiation and appetite centers, and can cause a different eating pattern. We also know that the microbiome can cause can lead to antibodies against hunger and satiety hormones in AN, and also that there is changes in the reward circuits in binge eating and bulimia. There is a dopamine signal in the nucleus accumbens when the patient eats very much, and in anorexia there is a stimulation of the nucleus accumbens when the patient avoids eating. That is the reward in the anorexia. But let's move to the atypical eating disorder. I wanted to say that binge eating disorder are not atypical anymore. They have found their way in the DSM-5 categorization as a specific eating disorder. Maybe we can talk because of the obesity that anorexia that we see after bariatric surgery, or that we can see after bariatric surgery, is an atypical eating disorder too, that are the patient becoming compulsive, that don't want to gain weight again, and shows signs of anorexia nervosa after bariatric surgery. A more classical type of atypical eating disorder is the orthorexia, defined by an excessive mental preoccupation with healthy food, focusing on food quality, categorizing food into dangerous or healthy groups, with a negative impact on quality of life. Group at risk are women or adolescents, and risk factors are again body dissatisfaction, anxiety about body shape, stress, and there can be a shift to anorexia. Then we come to the muscle dysmorphia, or reverse anorexia, or bigorexia, an eating disorder that affects mainly male. For males too, have gravitated towards gaining more weight and becoming muscular. This is caused by changes in cultural ideas in the movies, magazine, TV stars that present almost perfect bodies. Popularity of bodybuilding has been increasing with the desire of to have a lean and muscular body. Muscle dysmorphia is not only an eating disorder, can also be classified as a body dysmorphic disorder. Body dysmorphic disorder is a mental disorder characterized by a distressful preoccupation with a perceived defect in appearance that is not or the minimal or the unnoticed by others. In the DSM-5, the psychiatric classification, it was added to the OCD, to the obsessive compulsive disorders, and with the presence of comorbid disorders such as substance addiction, major depression, eating, and personality disorders. Core symptom is body image disturbance. Like in anorexia, anorectic people think when they look in the mirror, thinks that they are obese, but they are underweight. And patient with muscle dysmorphia thinks to be too thin or underweight, being muscular, and they don't show their body because they are ashamed. Muscle dysmorphia is in the cross of many psychiatric diagnoses, and also in these disorders we found that there is a significant negative correlation between self-esteem and body dissatisfaction. Bigorexia usually begins between 17 and 24 years of life. Patients with muscle dysmorphia avoid challenging social or professional activities due to the need to maintain their excessive exercise and rigid diet. Can lead to serious clinical disorders, loss of employment, loss of family and friends, depression and suicide, because they are very concentrate on their training practices. It can come to kidney failure, heart disease, to eating disorders, and use of dietary supplements and anabolic androgenic steroids. Maybe then endocrinologists are asked to prescribe the testosterone by these patients to become more muscular. I had 2 patients who have asked me to prescribe the testosterone because the endocrinology didn't want to. Maybe we can talk later if this is a phenomenon that is known. There is a gradation of traditional modes of consumption. At the beginning, the patient want only natural foods without supplementation or substitution, and with growing severity of the illness, they take various supplements, protein products, pro-hormones, but only products without medical prescription. Then in the next degree, they take prescribed drugs such as ephedrine, anabolic steroids, testosterone. In the next phase, they take thyroid or growth hormones, diuretic, insulin. And the last degree is then street drugs such as marijuana, speed, cocaine, ecstasy, also because of the comorbid anxiety or depression. Treatment, what we can do with this atypical eating disorder. Studies say to reinforce levels of self-confidence, looking for other sources of healthy self-esteem, encourage to express feelings, reinforce them positively. There are, like other eating disorder, it's very difficult to express feeling, to recognize feeling by others, so we have to train them in this way. Remind them that they are not the only ones with concern about appearance. Often the patient had the impression to be the only one on the world with these problems. Discourage from all or nothing thinking. that it's also very frequent in eating disorder, all or nothing, black or white, and discourage also the idea that the negative body image is inevitable. Then clarify that media should not dictate how one looks, that we can eine Eigenidee from the Körperzusammenstellung, and discourage correlation between body weight and success, maybe also by sport activity teachers and so on. Then we come to the diabulimia, maybe also interesting for endocrinologists, that affects predominantly girls and young women with diabetes type 1. 30% of them stop taking insulin and abandon the diabetic diet to reverse weight gain. They want to lose weight because of the eating disorder. They may feel overwhelmed by the constant focus on nutrition and medication, and a previous eating disorder could be a risk factor to develop after diabetes. And damages could be the damages of the diabetes that are well known. Age of compensation is from 12 to 45, and 87% being aware of the serious consequence of this eating disorder, but choosing to continue restricting insulin, but because they don't want to gain weight. Sometimes this eating disorder also include bulimia, laxative use, and excessive exercise, which can occur with or without insulin misuse. Like other eating disorder, this atypical eating disorder can be caused by traumatic events, such as sexual abuse, family breakdown, or bullying. And the treatment targets intervention that targets trauma and beliefs about weight and appearance. Focus on strategies to cope with a long-term condition like diabetes. Focus on positive relationships to reinforce self-esteem. And classical cognitive behavioral therapy and for the adults, and family-based therapy for the adolescents. And it's very important that there is a good collaboration between physical and mental health professionals because of the association diabetes and eating disorder. Then drunkorexia is not so well known. Composed from drunk and anorexia, prevalent among younger women between 16 and 26 years of age. And that is a combination of a deliberate reduction in calories with a planned excessive consumption of alcohol. Also they don't want to gain weight, and so they diet, and then they can have binge drinking. Since alcoholic beverages are known to have a lot of calories, the meal before binge drinking is safe in order to compensate the daily caloric amount. Like other eating disorder, restricting calories during stressful or chaotic times can be a strategy to exert control over life when the patient have things that they are no control at all. And again, underlying trauma, such as sexual assault, traumatic life event, death of a loved one can be a cause. And if alcohol is consumed regularly, it can come to the damage of the alcohol in the body. Other authors speak of alcoholemia, not from drunkorexia, because the patient could also exercising excessively or drinking excessive amounts of alcohol to become sick and therefore purge, also vomiting. That's a bulimic, the purging form of eating disorder. There is a correlation with body dissatisfaction and exercise, excessive exercise and physical fitness. And we know that regular exercises have been found to drink more on days on which they were active because of anxiety. And compared to control, patients with bulimia have more impulsive, self-destructive traits, personality traits, scoring high in novelty seeking. That refers to a strong response in the reward circuit to novel experience, so sensation seeking, we can say. There is a need of transdiagnostic prevention programs targeting both eating disorder and addiction. There are not, we don't have structured programs to treat these atypical eating disorders. And then I come to the last atypical eating disorder, selective eating disorder, usually beginning in childhood and may resemble the picky eating behavior of most of the children. That is well known by children that they are selective in the first years of life with food. But then by selective eating disorder, we can see this also in adulthood with two variants, an avoidant restrictive variant that we can call ARFID. It's eating disorder in young people and adolescents with very restrictive eating, with little interest for certain foods, with avoiding certain foods, frequently fruits and vegetables, eating pommes frites, so fries, and so not always healthy food, because the patient thinks that they are safe. Maybe the child thinks these foods that taste so well that they are safe, and they don't involve fear feelings, but can also due to sensory characteristic or a sensory processing disorder in the brain. We don't know so much, or the family dynamic, or the traumatism, divorce, moving house. And more recently, we have found in a study that there is a genetic aversion to vegetables, also genetic codes, not only sensory processing disorder or traumatic experiences. Can lead to selective eating disorder, can lead to anxiety, depression, and social impairment. We see patients that only eat food considered to be safe, avoiding foods with a particular taste, texture, or color. And they are distressed when encouraged or forced by the parent to eat these avoided foods. Maybe they have an experience of choking or vomiting, leading to emetophobia, a fear of vomiting, and they don't want to eat these things because they have panic attacks. They associate in the brain food with danger, and also in this eating disorder, that could be a coping strategy, trying to exert control over life. In severe condition of malnutrition, we have the somatic complication of the anorexia. or of the obesity. I have 2 obese patients with selective eating disorder. Treatment, again, CBT for adults and family-based therapy for young patients. There is evidence for hypnosis, then can, oh, sorry, yes, I will go faster. And exposure and response prevention, where we try to make the patient sure to eat the avoided foods with the good teamwork. Then only as a repetition, CBT. There is a manual how to treat eating disorders with motivation at the beginning, and then treatment of the eating disorder symptoms and of traumatism and personality disorders. For adolescents, FPT is state of the art, and there are manuals from Locke and Lagrange, the Maudsley treatment, well known in the child hospitals to treat anorexia. But for the adults, there are programs too of family-based therapy, focusing of what keeps anorexia going, unflexible thinking style, high expressed emotion of the relatives, difficulty with emotion, and anorexia as an identity, and the parents are guided to better emotional support the patient and to reflect their own parenting style. Then we have inpatient treatments for anorexia nervosa, but also for other eating disorder that is modular, from motivation to stabilization, with modification of the behavioral modification to reintegration and social reintegration and stabilization, with interdisciplinary team, inpatient and outpatients program, and on the end I wanted to say with the metrilaptine for the compulsive excessive training behavior that we have studies on it. We are running studies on the transcranial Hirnstimulation and on psychedelics, psilocybin. We are commencing to make thinking more flexible in anorexia. Okay, that's all. I'm sorry for being too long.
Sorry, I didn't want to bother you, but you asked me to show you 10 minutes before. So it's very interesting, I think, and I observed that every pediatric endocrinologist and obesity expert has a lot of such patients in his under his care, I think. And now I would be interested in some questions from your side. Okay, and yeah.
Thank you, Patrick, for your excellent presentation. Do you have studies about the success of hypnosis treatment?
I don't know if there are studies that is a clinical procedure. I don't think there are studies at the time.
Does the diagnosis of muscle dysmorphia requires the measurement of total muscle mass and its distribution in the body?
I don't.
Or not?
I don't think so. That is a psychiatric diagnosis in the in the main course, and so we look at typical thinking process of the patient that are typical eating disorder process, and so we came on the diagnosis. We don't have to look at the muscle mass.
The other question is, if we think about obesity, since we are obesity association, would you consider that you have also the adipose dysmorphia, which would be probably more genetic, like steatopedia, which occurs in South Africa in black women who are not obese. They have a body fat distribution which is not typical. Most of the fat is stored in the buttock, and less in this part. So it's also a dysmorphia, isn't it?
Yes, I think so. We can say that is a part of a body dysmorphic disorder too. Yes, or in the obese people too. Many obese people don't perceive themselves as too obese, and then we saw, because of the body dysmorphic disease, that after bariatric surgery, the patient long time have the idea that they are obese, and they in the bus they go they go away because they think they are obese, and there is this body dysmorphic disorder. It's long to treat. But yes, in the African people too.
I don't know how it's in your consultation, but the body dysmorphic disorder is not so rare in adolescents, and especially I did see some transgender people that were, especially in young people, it was not so clear whether it was more important to have another gender or another body image or another body. So it's really not very easy to differentiate, I think.
And after the operation of transgender adult people, we saw these body dysmorphic disorders to patients that don't perceive another sex.
How it's about the frequency of eating disorders after therapy or after bariatric surgery for obesity? Are there so about?
About one third, I would say.
Okay, it's from your view.
Yeah. Yes, I don't know the studies.
Okay, so we have to consider that as a true problem. Okay.
But we know that depression, anxiety, and even binge eating improve after bariatric surgery, but body dysmorphic disorder remain 4 or 5 years after bariatric surgery.
Okay.
It's harder to treat.
Okay, yeah, thank you. Thank you. So it was not so known until now. Okay, thank you. So there's no question in the chat. No question in the auditorium. So, Patrick, thank you for this great overview of the eating disorders. Thank you.
Thank you very much.
Now we come to the next speaker.
Thank you. So stigma is a huge problem for the patient with obesity and even for the obesity management. So it decreases the success of obesity treatment. So I'm very happy to introduce the Professor Rebecca Poole. She's from US, Connecticut, and unfortunately she won't be here. She, for obvious reason of time shifting, she's not live. So her talk has been recorded. So Professor Poole is a deputy director for the Root Center for Food Policy and Obesity and professor in the Department of Human Development and Family Studies at UConn. She earned her PhD in clinical psychology from Yale University and has conducted research on weight bias for more than 50 years, has published numerous studies on weight-based bullying in youth, weight bias in healthcare and media, interventions to reduce weight media, and impact of weight stigma on emotional and physical health. And she's really considered as a leading international expert in the field of weight bias. So she will speak about the nature and health consequences of stigmatization. So yes, if we, thank you.
Hello, everyone. I'm Rebecca Poole from the University of Connecticut, and I'm delighted to be speaking to you today and to be part of the 16th annual conference of the Swiss Association for the Study of Obesity. In this session, I'll be talking about the nature of weight stigma and its implications for health and well-being for people who have obesity. So specifically today, I'd like to first summarize evidence regarding the nature and extent of weight stigma, and then share with you our research examining the consequences of weight stigma for both psychological and physical health. And I'm going to focus on two important psychological mechanisms that can help explain how stigma impacts health, which is through internalized weight bias and the coping responses that people use to deal with weight stigma. Well, let me first begin by briefly defining weight stigma, which can be broadly understood as social devaluation of people because of their body weight or body size. And at the foundation of weight stigma are strongly ingrained stereotypes that people who have higher body weight or larger bodies are lazy, lacking in willpower and discipline, unmotivated to improve their health, and personally to blame for their weight. And these societal stereotypes are pervasive, and they set the stage for different forms of prejudice and unfair treatment. And if we're to have a comprehensive understanding of the complex causes of obesity, we really need to include acknowledgement of the role that weight stigma plays. There are many compelling reasons why we need to be considering weight stigma in the context of obesity. Weight stigma penetrates the lives of people who have obesity, who face injustices because of unfair treatment in multiple domains of society. Stigma interferes with treatment. It has numerous consequences for health, which I'll be talking about today. And beyond this, weight stigma also affects public views of others who have obesity, and it affects how obesity is framed in public health messaging. And stigma can also affect the research and the science that we do on obesity, as well as policies that are relevant for people who have obesity. Before I jump into a discussion of the health consequences of weight stigma, I want to first comment on the prevalence of weight stigma in adults and in youth. So across national studies in the US, pooled prevalence estimates of weight discrimination for people with high weight, such as obesity, range from about 19 to 40%, with the highest rates of weight discrimination among those with the highest BMI. And in a series of national studies that we've conducted, we see fairly consistently that approximately 40% of American adults report that they've experienced some form of weight stigma, whether it's in the form of teasing or mistreatment. And we see this high prevalence of weight stigma and discrimination across different countries. So my team recently completed a multinational study which examined experiences of weight stigma among a sample of just under 14,000 people across 6 Western countries. And this is a weight management sample of adults who are members of WW, formerly Weight Watchers. And our data show high percentages of adults across these countries reporting that they've been teased and mistreated or discriminated against because of their weight. We found very few and often no differences in people's reported experiences of weight stigma between these different countries, despite the fact that prevalence rates of obesity actually do differ across these countries. And for many people, experiences of weight stigma begin in childhood and adolescence. And in some of our recent research with a large sample of adults actively trying to manage their weight, almost half, 46%, reported that they first experienced weight stigma during childhood or adolescence. And we found that people who reported these experiences, that the frequency and distress related to stigma were higher during childhood and adolescence compared to other time periods in their lives when they were older. Now, consistently in the literature, we see that youth who have overweight or obesity are more commonly bullied because of their weight compared to youth with lower body weights. And one's risk of being bullied about weight significantly increases as BMI increases. These findings persist regardless of factors like race or ethnicity, income, academic achievement, or social skills. And when we look at the prevalence rates of weight-based bullying in diverse samples of youth with respect to body weight distribution and race and ethnicity, we see that at least a quarter to almost one half of girls are reporting weight-based bullying, and at least 20% to over 1/3 of boys are. Now, the studies that I've highlighted here primarily refer to adolescents. If you look at the first row of this table, this involved a large sample of ethnically diverse adolescents, and both girls and boys were more likely to be bullied for their weight or their physical appearance than for their race or ethnicity, their sexual orientation, or their disability status. Now, in addition to weight bullying from peers, what is particularly concerning is research documenting parents and family members as sources of weight-based teasing experienced by youth. And I've highlighted a handful of our studies here where we've asked adolescents and adults about their different interpersonal sources of weight stigma in their lives. And family members are often one of the most common sources reported. So you can see here how high these percentages are of people who say that their parents or family members have stigmatized them about their weight. The lowest is more than 1/3 of participants, and the highest is almost 3/4 of participants. Now, beyond family and peers, weight stigma is also a problem in the healthcare setting. So several decades of research have documented evidence of weight stigma in the medical and clinical care setting. This often occurs as negative and stereotypical attitudes expressed by healthcare providers towards patients with obesity. Stereotypes by providers include views that their patients who have obesity are non-compliant with treatment, lazy, lacking in self-control, weak-willed, sloppy, unsuccessful, et cetera. And these attitudes have been documented by a range of healthcare provider specialties, including physicians and nurses and dietitians, mental health professionals, and also by students who are training in professional health disciplines, such as medical students. And it does appear that patients are aware of these biased attitudes in their healthcare providers. So as an example from our own research, I've summarized 3 studies here with large samples of adults who have high body weight. And when we've asked them if they've experienced weight stigma from a healthcare professional, you can see how high these percentages are, particularly for weight stigma coming from doctors, which was reported by more than 2/3 of people in our studies, but also from other healthcare professionals as well. So given the high rates of stigma and the different interpersonal sources of weight stigma, how does weight stigma impact health? So first of all, a key consideration here is the emotional distress that weight stigma creates for people who experience it. We know from substantial research evidence that weight stigma induces a range of psychological consequences, including higher levels of depressive symptoms, anxiety, low self-esteem and poor body image, increased levels of substance use, and even suicidality. So there are higher levels of suicidality reported by people with a high BMI who have experienced weight stigma or bullying compared to same weight peers who have not experienced stigma. And the psychological distress of weight stigma has been documented in both adults and in youth, in both community samples and weight loss treatment samples. And importantly, findings persist after accounting for BMI. Now, this is important because it tells us that it's not just body weight per se that is leading to this psychological distress, but rather it's the experience of stigma. Now, the emotional toll of weight stigma on mental health is very damaging, especially when we consider that weight stigma can come from close family members and friends. And so those close relationships are not necessarily available as social and emotional support. And as we live in societies that do very little to challenge weight stigma, there aren't clear ways for people to seek support if they do experience stigma, and that can worsen their stress. And in our research, we see that emotional distress seems to be particularly heightened for females and especially for girls during adolescence. So as an example here, we conducted a study of 394 adolescents who had been bullied about their weight during the past year. And compared to boys, girls reported more negative emotions. They were more likely to feel sad and depressed and worse about themselves, as well as feeling badly about their bodies and generally angry. And these emotions were also present in boys, but we saw higher levels in girls. And this is not surprising when we consider the very stringent ideals for female physical attractiveness in Western societies and the shaming and the judgment that occurs on public platforms like social media, which really disparage women who deviate from these ideals and who are judged very harshly for their body size or their higher weight status. So the psychological harm of weight stigma is really important to consider in both youth and adults. Now, a particularly striking finding that has emerged in prospective research is experiencing weight stigma predicts weight gain and obesity over time. Now, these findings persist after accounting for baseline body weight and sociodemographic factors, and it appears that other forms of discrimination, such as race or gender-based discrimination, don't have these same effects on weight gain. It seems to be unique to weight-based discrimination. This evidence has started to help us understand weight stigma not only as a psychosocial consequence of obesity, but also as a psychosocial contributor to obesity. And similarly, we're seeing evidence that people who have experienced weight discrimination have a significantly higher risk of diabetes, cardiovascular disease, arteriosclerosis, and heart conditions. Again, even after accounting for BMI or stressful life events, physical activity, etc. So a key question here is, why is weight stigma contributing to weight gain and poor health? What are the mechanisms here? So first, it's important to think about the ways in which the psychosocial stress of weight stigma contributes to weight gain and obesity. Psychological distress is itself a negative outcome of weight stigma, but it can also reinforce unhealthy coping strategies in response to weight stigma, and it can lead to self-blame and internalization of weight stigma, both of which can in turn lead to maladaptive or unhealthy eating behaviors that worsen health and may contribute to weight gain. So I'd like to share with you some of our recent studies that highlight these links between stigma and maladaptive eating and other health consequences, and how people's coping strategies to deal with stigma and internalization of this stigma play an important role here. So first, a substantial amount of evidence shows that weight stigma is associated with maladaptive eating behaviors. And in particular, binge eating has emerged as a very common correlate of weight stigma, and not just in adults, but also in youth. So for example, we know that adolescents who experience weight stigma have an 80% greater likelihood of severe binge eating. We also see links with weight stigma and increased food consumption, unhealthy weight control, disordered eating patterns, and emotional overeating. So those who experience weight stigma have a higher prevalence and a higher frequency of these unhealthy eating patterns. And again, these links are present in both youth and adults, in community and clinical samples. And importantly, some research in this literature is also controlling for BMI. Now, one of the reasons why we are observing maladaptive eating behaviors in people who experience weight stigma is that people may be coping with the emotional distress of weight stigma by turning to food. So about 15 years ago, I began studying this issue, and we started with a sample of 2,400 women in a self-help weight loss organization. And we simply asked them how they were coping with weight stigma that they experienced. And women reported using all sorts of different coping strategies. Some were positive, some were negative, but a striking finding was that almost 80% reported that they tend to turn to food as a coping mechanism, and that eating temporarily relieved their distress. And as we know from the psychology literature, stigma is a stressor, and eating is a common strategy in response to stress. So that certainly makes sense in the context of these stigma findings. And we've continued to see similar findings emerge time after time in our studies since then. This slide shows a more recent example. This is a national community sample of about 2,400 US adults. And we found that the more weight stigma that people reported, the more that they reported coping with stigma by engaging in disordered eating behaviors, increased eating and food intake, and avoiding physical activity. Now, unfortunately, we're seeing some of these links between weight stigma and unhealthy coping responses during the COVID pandemic as well. We published a study in 2020 from the Project EAT cohort study, which is a longitudinal cohort study led by Diane Newmark-Steiner at the University of Minnesota. And it has followed almost 2,000 adolescents for more than 15 years into their mid-30s. So data from this cohort were collected in the spring and summer of 2020 to assess people's health behaviors during the pandemic. So for this particular study, we found that pre-pandemic experiences of weight stigma that adults had reported back in 2018 predicted worse eating and emotional distress during the COVID outbreak compared to people who had not reported stigma before the pandemic. And specifically, those who reported that weight stigma in 2018 had a much higher level of using food and eating as a coping strategy for dealing with stress, and they were binge eating much more frequently. So this tells us that under times of pandemic, when there's considerable stress and upheaval, these patterns are persisting, which obviously have concerning implications for health during this time period. Now, unfortunately, these eating coping responses in reaction to weight stigma appear to begin quite early in youth and adolescence. So as an example here, this slide is from a study we did with just under 400 adolescents who had been teased or bullied about their weight in the past year. And we found that both boys and girls who reported emotional distress in response to weight bullying were more likely to cope by increasing their food consumption, binge eating, and avoiding physical activity. So these responses can really set the stage for longer-term patterns that become ingrained over time and which contribute to unhealthy eating behaviors and weight gain. And we do see that weight teasing in adolescents really can have long-term implications for both eating behaviors and weight gain. So this slide shows some longitudinal analyses with the Project Eat study cohort. We found that both boys and girls who were teased about their weight as 15-year-olds and adolescents were more than twice as likely to have obesity and more likely to be eating to cope with their emotions 15 years later in their mid-30s. And this was compared to peers who were not teased about their weight in adolescence. These analyses controlled for baseline body weight and sociodemographics. And so again, we're seeing that weight stigma has implications for future eating behaviors and weight gain in adulthood, even when these experiences happen in early adolescence. Now, in addition to maladaptive eating behaviors, we see from research that when people experience weight stigma, they're less likely to engage in physical activity and exercise, oftentimes because physical activity settings are places where they feel vulnerable to stigma or shame about their weight. So people sometimes cope with these experiences by avoiding physical activity. And in adults, experiencing weight stigma induces negative feelings about engaging in physical activity, lower intentions to do so, and avoidance of exercise. And in youth, we see the same pattern. So very high percentages report being teased about their weight during physical activities at school, which not surprisingly can lead kids to avoid physical activity classes or sports altogether because they want to escape these teasing experiences, and it reduces their engagement and enjoyment of physical activity. Now, evidence also shows that the psychosocial stress of weight stigma can exert negative effects on physiological stress. And that obviously has implications for body weight as well. So people who experience weight stigma or discrimination have elevated stress responses, including worse, higher levels of C-reactive protein, higher blood pressure, higher cortisol, higher A1C levels. And these findings persist independent of BMI. So that again tells us that it's the experience of weight stigma, not body weight per se, that is increasing vulnerability to these physiological responses. So when people react to stigma with elevated psychosocial distress, this can in turn have an adverse effect on their physiological stress responses. Now, what's interesting here is that even if people don't experience weight stigma directly, just being exposed to weight stigma that we see in the media can have negative implications for physiological stress. So my colleague, Natasha Shvei, led several experimental studies to look at how exposure to weight stigma in the media affects people's stress responses. She brought women of different body sizes into the lab for individual sessions. Women were randomly assigned to one of two conditions. In one condition, the woman watched a 10-minute video depicting clips of neutral nature scenes and advertisements that had nothing to do with body weight. In the other condition, they watched a 10-minute video consisting of clips from the most popular television shows and sitcoms or films in which characters were stigmatized, stereotyped, or made fun of because of their weight. And participants' salivary cortisol was assessed both before and after watching either the weight stigmatizing or neutral video. What we found is that those who watched the stigmatizing video had significantly greater cortisol reactivity compared to those who watched the neutral video. And this occurred regardless of women's body weight status. So women find these stigmatizing media clips to be stressful to watch, even if they don't have a high body weight themselves. And these findings persisted after accounting for a range of variables, including minutes since waking, days since last menstrual cycle, age, BMI, stress, depression, etc. Now, in addition to adverse coping responses to weight stigma, another way in which weight stigma can lead to poor eating and poor health is how people interpret stigmatizing situations through a process called internalization of weight bias. Now, what can happen when people experience weight stigma is that the negative societal judgments that they face can become an internalized process of negative self-judgment and self-blame. So internalizing stigma happens when people are aware of weight-based stereotypes and they apply these beliefs to themselves and they engage in self-directed stigma and personal blame. And internalized weight bias is fairly common in the general population. So national studies in the US have found that about 1 in 5 people have high levels of internalized weight bias, and over half of people who have obesity are engaging in internalization. This is especially likely among women who have a higher BMI and who are trying to lose weight. Now, why this matters for health is because research shows that internalizing weight bias can have the same negative consequences for eating behaviors and weight-related health as experiences of weight stigma. And in fact, research is starting to show that self-blame and self-stigma is predicting poor health more than the experience of stigma itself. And these links are remaining after accounting for people's body size and after accounting for how much stigma they've actually experienced. And unfortunately, we see that internalizing stigma is not unique to adults. So emerging research with youth and adolescent samples, both community samples and treatment-seeking samples, shows that they are also internalizing and blaming themselves for weight stigma and bullying, and that this internalization is similarly associated with negative health behaviors and psychosocial consequences. So this is something that we really need to be looking out for and addressing with children as well. Now, what we've seen in our studies is that internalization of weight bias has some concerning implications for weight management. I've highlighted an example here, which is a study that we conducted with adults, and this was a group of adults who had lost at least 10% of their weight in the past year. Some of them had maintained that weight loss while others had regained it, and we wanted to see what role stigma might be playing in these outcomes. Now, what we found is that typical behaviors linked with sustained weight loss, like dietary monitoring and self-weighing, weren't actually significant in these groups, but there was unique predictive value of weight stigma, and specifically internalized stigma, when it came to who maintained their weight loss and who regained their weight. Specifically, what we found is that for every 1 point increase in internalized weight bias using the measure that we had to assess this, the odds of maintaining weight loss decreased by almost 30%. And this evidence suggests that the internalization and the self-blame resulting from stigma might be really interfering with people's efforts to maintain weight loss, regardless of how much weight stigma they've experienced. And this may be one of the reasons why we're seeing internalizing weight stigma as an issue that seems to be interfering with weight management. So an example from our work here is a large US study that we did with adults engaged in weight management. These were adults enrolled in WW, formerly Weight Watchers. We found that internalized weight stigma, but not experiences of weight stigma, was associated with lower odds of weight loss, higher odds of weight gain, worse weight management behaviors. And these findings persisted after we controlled for people's BMI and sociodemographic characteristics. So internalized weight bias appears to be playing a role that really creates barriers when it comes to weight management. And similarly, in the multinational study that I mentioned earlier, we looked at this here as well, and we found that internalization of weight bias played a role in both eating behaviors and emotional well-being. So when we controlled for participants' demographic characteristics and their experiences of weight stigma, we found that higher internalized weight bias was associated with greater weight gain in the past year, more use of food and eating as a way to cope with stress, lower self-efficacy related to eating and physical activity behaviors, worse body image, more stress, and worse health-related quality of life. And this was found across these different countries. And so, these findings suggest that internalized weight bias is really a robust correlate of poor weight-related health across different Western countries. Now, if we return to the issue of how people cope with weight stigma, we are starting to see evidence that internalization of weight bias aligns more with unhealthy coping strategies in response to weight stigma. So, for example, what we have found among people engaged in weight management is that those who internalize weight stigma use more maladaptive coping strategies when they have those experiences. So, for example, they're more likely to turn to disordered eating or avoiding exercise. And they are also reporting fewer adaptive coping strategies like seeking social support or engaging in positive self-talk. So, in summary, all of this evidence shows us the ways in which weight stigma can ultimately contribute to weight gain and obesity, because the psychosocial distress of experiencing weight stigma can give way to both maladaptive coping strategies to deal with this distress, as well as internalization of stigma. And both of these can reinforce unhealthy eating behaviors and other risk factors, which can contribute to weight gain. This can create a harmful cycle because increased weight gain makes a person more vulnerable to experiences of weight stigma, which sets this whole pathway in motion again. So again, in this sense, it's really helpful to think about weight stigma as both a psychosocial contributor to obesity as well as a psychosocial consequence of obesity. Now, I do want to highlight that this harmful feedback loop has relevance and concerning implications for different kinds of populations who are dealing with other health issues or other stigmatized identities. We've examined links between weight stigma and health in sexual and gender minority adolescents. This slide summarizes a US study that we did with a large sample of sexual and gender minority adolescents, and we found that weight-based teasing was very common across diverse body sizes in these youth. If you look at this table here, you can see that the highest rates of weight teasing from peers and family members were experienced by adolescents with the highest body weight, but there were also high percentages of weight teasing at lower body weight categories. Now, this highlights the importance of recognizing that weight stigma is not just about having obesity. It really can affect people at different body weights and sizes. And in this same study, we also found that being teased about weight significantly increased the odds of a range of different adverse health behaviors, including maladaptive eating behaviors like binge eating and using food to cope with stress, as well as worse mental health, lower self-esteem, higher depressive symptoms. And these health consequences occurred regardless of their body weight, again, reinforcing that weight stigma has implications for health regardless of body size. And so we're seeing these links between weight stigma and adverse eating behaviors and mental health in vulnerable populations. And what's concerning about this study in particular is that we know that these adolescents are already being stigmatized for their sexual or gender identity. So because of their weight status, they also have multiple stigmatized identities, and this can compound their health consequences further. We've also done some recent studies looking at weight stigma in adults who have type 2 diabetes. And we found that over half of them reported experiencing weight stigma, and 44% felt judged about their weight by doctors. And we found that those who experienced weight stigma had higher diabetes related to stress and more binge eating, and were coping with stress by eating compared to those who had not experienced weight stigma. And we see the same pattern here for those who internalized weight stigma, who were blaming themselves. They were also more likely to have higher diabetes related to stress and worse eating behaviors and worse healthcare interactions and worse overall health. So we do need to be considering how weight stigma is impacting people who are already at risk for poor health. Now, beyond all of the health consequences that I've already mentioned here, it is important to highlight that weight stigma does impact healthcare and experiences of patient care. So research examining provider practices shows that compared to providing care to lower weight patients, that when it comes to patients with obesity, providers spend less time in their appointments and have less discussion with patients. They admit that they don't intervene as much as they think they should, and they have less respect for patients with higher body weight. And when we look at research studies of patients with obesity, we see that they're very aware of these biases in the healthcare environment. And as a result, they have lower trust in their providers. They're reluctant to talk about their weight. They perceive a lack of empathy and believe they won't be taken seriously. They often report that weight is blamed for unrelated medical problems, and they're more likely to switch doctors and avoid care. And related to this is internalization of weight bias again. So coming back to this issue of internalization, we've seen negative implications for this in our multinational study. And what we found is that compared to people who had lower levels of internalized bias, that those who had higher levels of internalization of weight stigma were more likely to avoid healthcare. They obtained less frequent routine checkups. They perceived that their doctors were negatively judging them about their weight and that their doctors had less respect for them and didn't listen to their needs. And this pattern was consistent across each of the 6 countries that you see here. And I should note that BMI was not associated with any of these healthcare experiences, only internalization was. So when we consider all of the links between weight stigma and adverse health and healthcare, it's very clear the ways that stigma reduces quality of life. It impacts many aspects of health, ranging from psychological distress to maladaptive eating behaviors to lower physical activity and physiological stress and weight gain and quality of care. So collectively, the evidence that I've summarized today really underscores why it's so important to consider weight stigma in the context of obesity and patient care. We simply cannot effectively address obesity through prevention and treatment if we do not also recognize and address the negative impacts of stigma on health behaviors and outcomes. Now, we are seeing increasing recognition of this. We're seeing it in the pediatric obesity field, which I've highlighted on the left side of the slide here. This refers to a recent article published in Pediatric Obesity, which highlights the need to address weight stigma as a legitimate barrier to providing care to youth who have obesity. And there's also been increasing recognition more broadly in the medical community about the harms of weight stigma in adults. And that has been evidenced by an international consensus statement and pledge from more than 100 medical and scientific organizations worldwide to support efforts to reduce weight stigma. And this was published in Nature Medicine last year. So we're seeing increased awareness that to treat obesity effectively, weight stigma must be addressed. Now, if you are interested in learning more about weight stigma and how you can address this issue in the medical community and in patient care, there are a number of educational resources that have been developed to really try to help healthcare professionals have supportive, productive conversations with patients about weight-related health. These and other free educational resources about weight stigma are available on the Rudd Center's website. And this includes informational slides and handouts, training, webinars, educational videos, really talking about what weight bias is, how it affects patients, and strategies for improving patient care and reducing weight bias. So I'd like to thank you very much for your time today. You can certainly feel free to contact me directly if you have additional questions or would like to learn more about this topic. Thanks very much.